Yes, I am Mrs. Stewart. She's a lady.
Mrs. Stewart. Okay. I got a letter from your GP that he was blurring of vision. Can you tell more regarding this, please?
What do you mean by blurred vision? I did have a problem with my vision. I did lose vision in my right eye completely 3 hours ago.
Okay. All the right hand. And you completely you miss. Is there any associated eye pain?
Yes, I had some pain during that time. Dr. Matabat, unmute yourself. I'm everyone for the feedback, for the background noise. Unmute yourself.
Okay, is it associated with reddish discoloration of your eye?
No.
Okay, any headache?
Yes.
Okay, there is headache. Any weakness in your limbs?
No.
Any numbness?
No.
Okay, did you lose your consciousness?
No.
Okay, any pain in your upper face?
In my face? No.
Oh, in your upper face, no pain. Okay. Any did you thrown up?
No.
Okay. You have diabetes, right? For how long you have diabetes?
For the past 5 years.
5 years, okay. What about your last hemoglobin A1C?
It was 7.7.
Okay. And what about hypertension?
I am also having hypertension for the past 5 years.
Okay. Any past history of eye problem?
Any past history of eye problem? No.
Any history of eye operation?
No, never.
Can you show me your medication list, please?
I'm receiving metformin 1 gram twice a day, gliclazide 160 milligrams before 120 milligrams before breakfast, and ramipril 5 milligrams once a day.
Okay. Are you adherent with your medication?
Yes, I am.
Okay. Any change in the dose?
Recent? No.
Okay. Any new medication added?
No.
Okay. Is that episode associated with hunger feeling?
No.
Is it associated with dizzy spells?
No.
Okay. Can I examine you when I'm talking to you, please?
Sure.
Okay. I will start by examination by checking eye, starting by eye, visual acuity.
Intact bilaterally.
Okay, and visual field.
Visual field is intact bilaterally.
Okay. Then I will check for eye movement.
Intact bilaterally.
Okay, I will check also for pulse to be sure it's regular.
Pulse is regular, no special character, equal bilaterally 80 beats per minute.
Okay, I will start a new exam also, power, tone, reflex, and gait.
That's a lot. Okay, how would you do that? Tell me, what are you going to do?
Okay, just for sensory. I will check for sensory only.
Which type of sensation you are going to check for?
Lower limb.
Lower limb. Superficial or deep sensation?
Superficial.
Touch or pain?
Touch and pain.
Touch or pain or both?
Both of them.
Both of them. All are intact.
Okay. Did you have a loose motion?
No.
Okay. Any tummy pain?
No.
What about your water work? Is it frothy?
No.
Any change in color?
No.
Any tummy pain or distension?
No.
Did you feel that you are early satiety?
Satiety? No.
Okay. I will check. I need to do fundoscopy also.
Fundoscopy.
Yes,
Fundus is coming up on the screen, and you have 2 minutes remaining.
Okay.
2 minutes remaining.
Can I know your concern, please, Miss Sawar?
What did I suffer from, and will it happen again?
Okay, I will ask you one question before. Are you taking this oral contraceptive pills or the hormone replacement therapy?
No.
Okay. I think from history I took from you, I think your problem is related to your diabetes.
We have
which
background
affect-
echo. Yep.
which affect your eye and causing block to your blood tubes of your eyes.
Mhm.
Okay.
You mean that I did suffer a stroke?
No. It is not a stroke. It is only an occlusion to your blood tubes, your eye blood tubes, because of your diabetes.
Okay.
Any other concern? Can I tell you, please?
No.
Okay, thank you, Miss Joan.
Okay. Would you like to tell the lady your plan of management?
Okay. She need ophthalmological. If you know, I will start blood thinning medication.
Which type of blood thinning medication?
I think Clixin or Warfarin, I'm not sure, but I think.
Okay. Let's fix that step by step. First of all, let's agree on a point. On the screen, those are the investigations, or those are the things that you did ask to examine for. Acuity, field, movement, fundoscopy, pulse, peripheral superficial sensations. Am I correct?
Yes.
Brilliant. Now, the first question by the examiner, what is your diagnosis?
I think it is central retinal artery occlusion.
Why do you think this is central retinal artery occlusion, and why not it is not a central retinal artery occlusion? What did you see in the fundus? Did you see anything in the fundus supportive of central retinal artery occlusion?
Really, I'm studying for MRCBI, and so fundoscopy is not included, and I'm not familiar with fundoscopy, but I suspect
Okay.
due to from the history.
This lady did lose her vision 3 hours ago. And when they did the acuity, the vision was intact. Central retinal artery occlusion, this type of lesion, do you think it is reversible?
No, it is not reversible after medication.
Okay, so this lady does not have central retinal artery occlusion. What else?
Maybe my differential may be a central vein occlusion also. Maybe
Central retinal
amyloid
vein occlusion is also irreversible, and both conditions are painless. So it is not a diagnosis.
Maybe optic neuritis.
Optic neuritis. In the context of what would be the reason for her optic neuritis?
No clear cause, but I think it is amaurosis focus, maybe the TIA, maybe trigeminal neuralgia.
The problem, Dr. Mu'tamid, is that you do not have a certain diagnosis. You went through the case, okay, but you do not have a specific thing to target. You have a general outline of the differential, but you did not rule any of them step by step. This is the main issue. You said that this is a case of optic neuritis. Optic neuritis in this lady is unlikely. TIA. This case is not a TIA. Why?
No weakness, no.
There is headache. There is headache. Thank you. TIA, Dr. Mu'tamid, is very unique, very characteristic because TIA is painless. Never, ever consider TIA with a headache. It can happen, but not in your exam. Agree?
Yes, I am agree with you.
Perfect. So, this lady is having a sudden, transient loss of vision. Let's fix first the differential, then we will fix the approach. Sudden transient loss of vision. Any case of eye disease or eye problem, we mainly focus on having a headache or not. This is your cornerstone, having pain or having headache. This will divide this kind of problem into either a painful condition versus painless condition. Sudden transient, painless loss of vision is the definition of TIA. Sudden transient loss of vision with headache, the abbreviation for that is TIMS. Temporal arteritis, idiopathic intracranial hypertension, multiple sclerosis, migraine, and space-occupying lesion. Space-occupying lesion usually either cancer metastasis versus something originating from the pituitary gland. Most likely to be a prolactinoma, less likely to be growth hormone releasing adenoma. This part, which is painful part, is applicable to all and every presentation of station 5 ophthalmology. So whenever you have a case of blurred vision of whatever reason, this is your differential. This is valid for 99.9% of the time.
Actually, I did not ask regarding milky discharge, so I'm in big trouble. Okay.
This is not the issue here. The point is coming. Hold on, step by step. First of all, temporal arteritis. Is that likely in this lady?
No.
Why not? Tell me about her headache.
Because she did not tell regarding joking education.
Did you ask about the claudication?
No, I did not ask, but I asked regarding tenderness in the upper face also. It's not around.
She had a headache. This is tenderness. Headache is pain. In the face, no. It does include or involve the temporal area. Temporal area is a completely different area than the face, with a completely different blood supply. Agree?
Yes, I'm agree with you, yes. So I asked wrong question.
Yes. Claudication. How do you ask about claudication?
Painful chewing.
Chewing. Do you think someone is having a headache with sudden loss of vision will be chewing food? No. Instead, he will be speaking or talking. Do you have any problem with your speech? Do you have any problem with your swallowing at that moment? But speech is more applicable. This is for the claudication. What else would you suggest to tell that this lady is having temporal arteritis? Her age. She's above the age of 50. Third thing to consider in this lady. If you ask me about symptoms of polymyalgia rheumatica which overlap with temporal arteritis, shoulder stiffness, you are absolutely correct. Not pain, stiff shoulders, stiff joints. So temporal arteritis, it can fit. This is the first one. Idiopathic intracranial hypertension. Do you think this lady is having any sort of increased intracranial pressure?
No.
You cannot tell. Why? Because you did not do any analysis of the headache given in the case.
I asked regarding thrown up vomiting. She's saying not there.
Okay, are those the main symptoms or the main factors by which you will determine that this lady is having an increased intracranial pressure? Is it a must-have in 100% of the cases to have an increased intracranial pressure that precipitates vomiting?
No.
So what is more specific when it comes to this point of increased intracranial pressure?
I will ask regarding this changing with the position of the head with coughing, sneezing.
Thank you. So 4 actions will increase the intracranial pressure. 4. Why 4? Because some surrogates may say no to coughing, may say no to sneezing, but they will tell you yes on leaning forward and straining. So keep it always as 4 actions can increase the intracranial pressure and increase the headache subsequently. But by definition, idiopathic intracranial hypertension is idiopathic. And what is the cardinal feature for having idiopathic intracranial hypertension?
Young obese female.
Thank you for mentioning obese. So this lady has to be obese, weight gain. There is no intracranial hypertension, idiopathic intracranial hypertension without weight changes, without weight gain. And this is not applicable in this case.
I did not ask regarding this also.
We did agree that you are missing quite a few points regarding the approach, and that's why we're discussing that at the moment. It is okay to make mistakes. That is perfect. The most important thing is to never do these mistakes again. Agree?
Oh, agree, yes. That's
Habibi, ta'alali. Then comes the points of the migraine. Is that migraine? You cannot tell. Why? Because you did not ask again about the headache. But if you ask me, I would say that this is a unilateral headache with a claudication in that age group, first attack, not precipitated or not preceded by an aura, so migraine does not fit. Is that multiple sclerosis? Possible.
No.
Optic neuritis. That was your diagnosis. However, this lady is 55 years of age, making the possibility of MS unlikely. Plus, optic neuritis or multiple sclerosis usually have motor, sensory, or bladder symptoms on top or along with the headache. And she doesn't have any previous attacks.
Also.
What is the typical duration for a migraine?
This
More than 4 hours. More than 4 hours. 4 hours to 72 hours.
4 to 3. Yes, 4 to 3. 4 hours up to 3 days. But this is the commonest form. Other forms do exist longer than that and shorter than that. So you cannot tell only by the duration. Rather, focus on the aura. If there is an aura, focus on the nature of the headache and having previous attacks in order to diagnose a migraine or having multiple sclerosis. Moving on, the last point is space-occupying lesion. That is either going to be cancer metastasis versus a prolactinoma. Cancer metastasis. Cancer. Did you rule out cancer in this lady, Dr. Mu'tamid?
No, I did not ask.
How would you rule out cancer in any patient regardless of the age?
Weight loss.
No.
Anorexia. B symptoms.
No. Can anybody guess the answer I'm waiting for?
Family history.
Family history of this clinical picture.
Clinical picture and family history. Whenever you hear the word cancer, I want you to remember 2 words, 2 points. Clinical picture and family history. And the earliest clinical picture of cancer is usually the iron deficiency anemia or being pale or tired. Family history. We have 3 questions for the family history. Any similar condition in the family, any disease that runs in the family, any family history of node cancer or sudden death. All that is in the PDF, Dr. Mu'tamid. Take a look at it.
Okay.
Then comes the prolactinoma. Is it possible for this lady to have a prolactinoma? For your patient to be having a prolactinoma?
I don't think so.
Why?
I did not ask regarding picture of prolactinoma. But
You don't have to ask about it. Simply speaking, a mass in the pituitary gland is not reversible on its own. Once it's there, it is there. It's treatment. So this one is a short, transient attack. This mass will not grow suddenly and shrink suddenly. So it is not prolactinoma. Make sense?
Yes.
So back to that case. The main point of, I would say, the take-home message from that case is, first of all, let's fix the pitfall paper. ورقة الخوازيق الجميلة. In the pitfall paper, you will start the first point by saying that any case of blurred vision, in the scenario, you have to start by asking, what do you mean by blurred vision? Blurred vision is a vague term. I need to know which differential I am going through. Is that sudden transient, or sudden permanent, or double vision, or color vision? I need to know what do you mean by blurred vision. This is the first point. Second point, analysis of any symptom. Yes, shoot, ask, huh?
Yes, Dr. Muhammad Hassan, I make a short list of blurring of vision differential which are 5, but inside you are telling me I lost my vision for 4 hours, so all my differential was out of
3 hours ago.
Yes.
We are coming to this point right now. Analysis of any symptom, whatever symptom, in whatever branch, in whatever system, is 8 points. This is the key to the diagnosis in all cases. Previous attacks, onset, course, duration, exacerbating, relieving, association, and timing. Previous attacks, critical in this case. Onset, it was sudden. Course, progressive, regressive, or stationary. You still have the loss of vision. Did you regain your sight? This is a missing question in your piece. Duration, exacerbating factors, relieving factors, both with examples. Association, we are always targeting the twins. Twins are a couple of questions, or let's say those are couples. 2 questions that come together. Whenever you ask the first question, you have to ask about the second one. And the most important twin in your history, in your case, till you finish the MRCP or the MRCPI, is going to be vision and headache. There is no case of vision without asking about the headache. And whenever you have a case of a headache, you have to ask about the vision affection. Other twins like polyuria, polydipsia, mouth sores, private area sores, and nausea, vomiting, weight changes, and appetite. So we have more than one twin, but this is the most important twin. Then comes the timing. Timing usually comes in 2 questions. Diurnal variation and did it wake you from sleep. This is the basic analysis of any symptom in any part in station 2, 5, or the long case of the MRCPI. Make sense?
Yes.
If you ask me those questions, I would have told you that, I would have said that I had no previous attacks. The onset of that was sudden, and the course was transient for only 1 hour. The duration was 1 hour. Exacerbating factors, I'm not sure. It cannot get any worse than that. Relieving factors, spontaneous relief. Twin, did you have a headache? Yes, I had a headache. So once you find something positive, you need to analyze it. So the headache will essentially fall into the 8 out of 8 plus 3 points. So it will be 8 plus 3 out of 8 for any kind of pain. Headache, chest pain, abdominal pain, whatever. You will add score, nature, and radiation. So what kind of headache did you have? Tell me about previous attacks of headaches? No. Onset, sudden. Course, it did start with the loss of vision, did end with the loss of vision. Duration, also 1 hour. Exacerbating factor, relieving factor, here we need to focus on the signs of increased cranial pressure. Does it get worse with coughing? No. Sneezing? No. I want it to be boring when it comes to this point. Coughing, sneezing, leaning forward, straining? No. Then, what about the score? If I give you a score from 1 to 10, 1 being the least, 10 being the maximum, how much would you grade it? She will give you a high score. This is a severe headache. So we'll give you a score above 7. What is the nature of the headache? Was it dull aching, throbbing? What kind of pain did you feel? Did it radiate anywhere? to your neck, to the back of your neck, or any part of your body? No, no, no. So this is the first point of in the pitfall. We need to make sure that we have proper analysis of any symptom. Agree, Dr. Mu'tamid?
Yes, I'm following.
Agree. Moving on. Also in the pitfall paper, proper analysis of diabetes and hypertension or any chronic disease. I hate paragraphs, everything in points. Whenever it comes to those 4 points to consider. 1 is the duration. 2 is the control. 3 is the medications. 4, the complications. For how long you have been having this condition? Tell me about your last hemoglobin A1C or 3 months hemoglobin reading. What was your last blood pressure reading? For any medication that the patient is receiving, you need to ask about compliance. Any side effects, any recent change in dose. Like you have said, complications of diabetes are essentially covering the hypertension, the micro complications and the macro complications. Micro will include the autonomic as well. Peripheral neuropathy, nephropathy, and retinopathy. Do you have any problem with your sensation, numbness or tingling? No. Any problem with your urine? Is it frothy? No. Any problem with the vision? Yes or no? Macro complications, any history of a heart attack, any history of a stroke or a mini stroke, any pain at the back of your legs that forces you to stop and is relieved by rest. This is the proper analysis of diabetes and hypertension. Agree?
Yes.
Agree. Let's focus on one point here to mention that I do not care about the diagnosis. Now we are discussing an approach, how to approach a case. So by having a proper approach, you will be able to reach whatever diagnosis you have in your exam, rather than giving you a fish and, okay, well done, Dr. Mu'tamid, you have done it right. No, this is not right. Then moving on. When it comes to the TIMS differential in your case, or let's put an approach now and apply that approach. So I will do analysis of the STEM. What is the STEM? Everything mentioned about the patient. We will start by the loss of vision or the blurred vision. What do you mean by blurred vision? I had loss of vision. 8 out of 8, I will get that was transient and painful. The second step should be the system involved, which is the CNS. Full neurological assessment. Questions. 8 questions, 9 questions, and you are able to do that properly. And here you will get to know about the headache. Then we will get to the point of the differential. This is the same sequence that we have discussed earlier. To reach a diagnosis, I have the TIMS. Temporal arthritis, it fits. Idiopathic intracranial hypertension doesn't. Multiple sclerosis, she's too old for that. Migraine, the headache doesn't fit. Space occupying lesion is irreversible. So in 5 seconds, if I think about it, I have a diagnosis already. Why did they mention the diabetes and the hypertension in this case? It's the distraction. Because everybody's going to say this is a case of TIA, but it is wrong because TIA is painless. The next step should be the examination. Following Dr. Mu'tamid?
Yes.
Examination. We start with the basic examination. The basic examination is something that you do in every clinical station. It is so easy, so fast. It takes 20 seconds, collects a lot of valuable information, and it makes you look good in front of your examiner. You need the proper impression. I will start by the dorsum of the hand. Can I take a look at your hand? The palmar surface of the hand. Then you will go joint by joint. You don't have to memorize it. The rest will remind you to check the pulse. The elbow will remind you to remember or to check the blood pressure. The shoulder will remind you to check for proximal myopathy. Then you will take a look at the patient's eyes for pallor or jaundice and ask the patient to open her mouth, looking there with a torch. How much time would that take? Simple inspection, 20 seconds. Valuable? Very valuable. Then comes the point of the targeted examination. Targeted examination. Whenever it comes to the eye, always ask yourself, where is the pathology? The pathology in the ophthalmology in station 5 is usually either in the retina or in the extraocular muscles.
Yes.
Following? So if the pathology is in the retina, it means the pathology, the diagnosis is in the fundus. So I need to jump on the fundus right away. Do not waste time outside. So I will check first the acuity to see if this patient is able to see me or not. Then I will go for the red reflex. Then I will get to do the fundoscopy. So the fundoscopy is the priority. I understand that there's enough time in the MRCBI to do everything. That's perfect, fine. But the first impression to be given by you to your examiner is going to be about what you are going to examine first. I'm thinking this is a retinopathy, so I'm going for the fundus rather than going for the eye movement. If the problem is in the extraocular muscles, I will get to do the acuity. Then, if you want to do the H-shape movement, fine. If you want to do the visual field, fine. It depends on the presentation. At the very end, I will go for the fundoscopy. So you can tell there is a difference in the sequence. It shows your priorities to the examiner. Do I make any sense?
Yes, yes. Yeah, very informative.
So 1 was analysis of the stem. 2 was analysis of the CNS, which is the system involved. 3, I need a proper differential and I need to do that targeted to get a diagnosis. Once I get the diagnosis, I will jump on the patient, go examine the patient. The basic examination, which is very important because we have a note in the pitfall paper that there is no neuro without cardio. So checking the pulse here is critical. Then I will go for the targeted examination. Visual acuity, red reflex, then I will go for the fundoscopy. Then I will wrap the case up by asking the examiner if I have more time, I will consider complete neurological assessment, including cranial nerves and cardiovascular assessment as well. Then I need the history part, which is the social, past, medication, family history, whatever is not covered, I will cover it here. And why do we take history in this case, Dr. Mu'tamid? Why do I focus on the social history? Because I need to offer these patients
If he's driving or something also.
Thank you. This is part of the social history. Social history is essentially 7 points. I told you I hate paragraphs. Everything in points. I know how many points before I even speak. Social history. This is the female or male history. That is in the PDF. You don't have to write it down if you wish to. Then comes the whom are you living with, supporting you at home. What do you do for living? Do you smoke? Do you drink alcohol? Do you drive? And illicit drugs, if you consider that as part of your differential. So those are 7 items that I'm going to write down in my paper up there in order to remember them before I enter the room. So driving is very important as well in this case, and offering help to this patient is crucial. Then comes the very end, the concern of the patient. What was my concern, Dr. Mu'tamid?
She is asking regarding a stroke.
No.
Actually,
my concern was, thank you, sir. شوف أخوك قال لك أهو. I did ask
يا معتمد
which is اسمع يا معتمد.
هو صاحبي وانا بعرفه.
اديله.
كله دكتور طارق بس.
Okay, so the concern was, what do I have and will it happen again? This is a standard type of pitfall in the exam where it's going to give you 2 concerns and you will end up answering only one. This will eventually precipitate or make you, Dr. Mu'tamid, unmute yourself. Eventually you will, God forbid, whoever does that will lose 50% of the case. You do not want that. 50% of the concern gone for no reason. So what did I have, or what do I have? Temporal arthritis. Will it happen again? There is a possibility. So how to end up the case or how to close the case properly? 6 points. one, I always start with the presenting symptom. Then, are you able to hear me? Dr. Mu'tamid, unmute yourself. Not sure my voice is clear.
Yes, I'm following. Yes.
We are.
Okay, perfect. So you will start by the presenting symptom, then you will name your diagnosis, then you will define this diagnosis. For that, you will form a multidisciplinary team. This team will be running further investigations, blood testing, and imaging, and you will arrange for another meeting to discuss the results. Keeping in mind 3 points. If you are going to start this patient on a medication or stop one of his medications. If you are going to admit him, and if you need to give this patient a proper painkiller if he's having any pain. This is standard closure for any case, long case MRCPI, station 2 MRCP, or station 5 the MRCP. So if I apply that to your case, I'm sorry to tell you that the loss of vision, and I will be marking myself throughout that. I'm sorry to tell you that the loss of vision that you have suffered along with the headache is related to a condition called temporal arthritis. This is an autoimmune disease. By that I mean it's a disease affecting the immune system, which is the system defending your body against infections. In your case, it is misdirected to attack your body, causing your symptoms. For that reason, we will form a multidisciplinary team, which will be running some investigations, some blood testing and imaging to confirm that diagnosis. And we will arrange for another meeting to discuss the results and the plan of management.
Multidisciplinary team, and we will arrange for another meeting. Now I need to admit you to start steroid and painkiller and assess you more.
Okay, why are you going to admit this patient?
Hello? Hello.
I'm talking about your patient. Why are you going to admit this patient?
Because I
For
want
IV steroids.
Yes, I
Right?
steroids.
But this lady has regained her sight 2 hours ago.
Maybe she will develop this again. Okay.
So there is no indication for starting steroids, systemic steroid or IV steroids at the moment. You will give that or keep that for cases of compromised vision on presentation. But this lady at this moment needs a diagnosis, and she needs to be maintained on steroids later on, and you'll start by oral steroids because the attack is gone.
Okay, that's right.
No need to refer to ophthalmologist.
What do you think?
She needs
She needs to be assessed, and this is why we did mention in
Hello? 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 এই চেক দেবে এগুলো বলছে আর কি
to arrange the time and to have priorities, and finally to always listen carefully to what is being said by the surrogate. It is not about hearing, it's about listening. وإذا قرئ القرآن تعرف تكملها؟ استمعوا إليه إيه؟ استمعوا وانصتوا. ايه اللي جاب انصتوا بعد استمعوا؟ ما الاثنين بمعنى واحد؟ لا مش بمعنى واحد. This is the difference between hearing and listening. Hearing استمع. Listening انصت.
Hearing by ears and listening by heart.
Thank you sir. الله يفتح عليك. So Dr. Mu'tamid, you will not make that mistake again or I will kill your headphone. Do you agree?
Okay, yes, I'm agree with you. I will make a good listening if I receive this case again.
Perfect. This is very good to hear. Thank you so much. Now, if anybody has a question here, let's get it over with in order to move on.
Good evening, Doctor. Can acute glaucoma consider one differential for this case?
We hate eye differentials. You are an internal medicine specialist. You are not working as an ophthalmologist. We hate eye differentials. Cataract, glaucoma, anterior uveitis, iritis. Do not say that for exam.
Okay, I will hate them. Thank you, Doctor.
Okay. Who else had a
Regarding
case?
driving, Dr. Muhammad,
Yes,
is applicable in this case?
of course.
To stop her
when,
from driving,
when you
if
stop
she's-
someone from driving. Generally
She said
speaking,
she
from
have-
station 5 and
You
station
have
4,
complete
yes.
regain of vision.
Exactly. But is there any guarantee that she will not lose the vision again? No. So she has to stop driving. Meaning, or the point to take home here, driving in station 5, 4, or the long case of the MRCBI, you need to stop the patient from driving if there is any disturbed level of consciousness. If there is any form of vision problem or affection. If this patient is having limited neck mobility, typically cases of ankylosing spondylitis. Those are 99.9% the cases in which you need to stop the patient from driving. Do we agree?
Yes, sir.
Regarding the dilemma of giving IV steroids, I disagree that this is my personal opinion, وأنا العبد الفقير إلى الله, that IV steroids are not needed at the moment since that attack was 2 hours ago and completely resolved. Instead of giving that, if you are not so convinced about it, tell the lady that you will be running those investigations urgently to give her the proper management as soon as possible to avoid any future complications. This is the diplomatic answer. To wrap up the case regarding this case. So thank you, Dr. Mu'tamid. Well done, my friend. Okay, Dr. Salma did send some questions here. Thank you, Doctor. Okay, Dr. Salma did send at the very beginning that we have patients suffering from palpitations and side effect of thyroxine. How to manage it? Shall we offer beta blocker or not? Dr. Salma, unmute your mic. Dr. Salma, are you there? You are the one asking questions at the very beginning of the chat. Okay, can anybody answer this question? What do you think should be the treatment for this case? Someone on thyroxine have been having or has been having palpitations. Should you stop the thyroxine or you should continue or you should give a beta blocker? Someone answer. Come on, try.
You should review his hormonal balance.
First of all, let's agree that palpitation, this is the problem. Palpitation is awareness of the heartbeats. This is a vague term. You have to have a diagnosis in order to make a decision. Meaning, this patient can be in sinus tachy, she can be a VTAC or even a VF. So the management of each will depend on the underlying diagnosis. Generally speaking, when someone is experiencing palpitation, sinus tachycardia because of the increased thyroxine level, I would decrease the dose. I'm not going to give beta blockers. Beta blockers are indicated. Why? What is the role of beta blocker in treatment of hyperthyroidism?
Hypercontraction.
antagonize thyroxine receptors.
Thank you. And this will calm the patient down, decrease the heart rate. So this is essentially symptomatic treatment till the level of the hormone is controlled. So it will depend on the underlying diagnosis of the palpitations, and this will decide if this patient is going to receive treatment for that or not, as urgency or emergency or not. If a patient has undergone thyroidectomy, then do I still need to examine thyroid by palpation and asking him to take a sip of water and palpate it? It depends on the presentation. If the patient is presenting with a neck swelling, definitely I will have to do that. If the patient is presenting with a scar in the neck and surgery in the neck and pain in the neck, I will definitely have to do that. Common sense. Patient with a neck swelling has concern about what you can do about swelling, although I am taking carbimazole and beta blocker regularly. Can you do anything to reduce the swelling? What do you guys think? Will the thyroid swelling regress on treatment or not? What should be the proper
Regress
answer?
by that treatment.
Is it not reversible at all or will partially improve?
Maybe partially improved.
Partially.
Thank you. So the proper answer for this question is I appreciate your worries on being on certain treatment or a proper treatment will make sure that this swelling is not going to get any bigger and it will improve on treatments. We will keep you on regular follow up and we will take it from there. This is the diplomatic answer. This is what the examiner is waiting for, to mention that this patient is not going to go home and you'll never see him again. No, he will be on follow-up. You'll give him the treatment, monitor the swelling. If it's getting better, the patient is fine, okay. If the patient is not okay, you will go for the surgery. What would be the indication for a case of neck swelling, thyroid neck swelling? When would you consider surgery, even if the patient is not symptomatic or not the patient not having any symptom of hyperthyroidism in case of obstruction? What do you mean by obstruction? Anything that the patient is able to do with his mouth. Speak, breathe, and swallow. This is an emergency for thyroidectomy, regardless of the underlying thyroid status, because this can compromise the patient's life. And that's why in the pitfall paper, again, we did mention that before, in any case of myasthenia gravis, it's called pass or fail the basis. Pass or fail the MRCP if, God forbid. Cases of myasthenia gravis, cases of goiter. Goiter essentially means a neck swelling, regardless of the underlying thyroid status. You need to rule out obstructive symptoms. Otherwise, the case is gone. The examiner can consider you as you have killed the patient because you let her go home with obstructive symptoms. She may die, suffocate, or whatever. So, if you want to pass, never forget the obstructive symptoms in cases of myasthenia gravis and the goiter. Myasthenia gravis is not obstructive, but the symptoms are essentially the same because of the weakness. Okay, those are the questions by Dr. Salma. Any other question here, anyone?
Dr. Muhammad, in the case of the patient and the communication scenario, patient epileptic and was controlled and given tramadol after a surgery for analgesia and developed a fit. Is it error or no? So
This is an epileptic patient who went for a surgery and
yes,
following the surgery, he took tramadol. Correct?
correct.
And that tramadol did precipitate.
A seizure,
What did it precipitate?
a fit.
Seizure. Okay. Let me ask a question first before we discuss this case. Tramadol, is it used to treatment for the treatment of seizures or not?
Not in the treatment of seizure.
But is it possible for tramadol to relieve a seizure?
Because it is an opioid.
What is the mechanism of action of tramadol? It is depressing. It's not a stimulant. So one of the rare side effects of tramadol is to have a seizure.
Yes.
Meaning that this is not a common side effect of tramadol, meaning that tramadol was given in the best interest of the patient, and the patient developed a complication of treatment. So it's a complication, not an error.
Okay, no.
Make sense?
Yes.
Okay. What
Dr.
else?
Mohammed, I have one question, please, if you don't mind. Can you repeat the swelling regarding the thyroid? So what we have to answer that swelling will decrease or not, because I missed that point, please.
This point, you will be keeping this patient. We will thank you for sharing your ideas with me. I can only imagine how stressful that is for you, how worried you are. We will give you the treatment, and the swelling should partially improve on treatment. And we will keep you on regular follow-up, and we will take the decision upon further assessment. As long as the patient doesn't complain of symptoms of obstruction. Okay, that was a good discussion.
Last question,
Yes,
please.
sir.
I'm Ahmed Nassar. Concerning the last question of the tramadol medication, it nearly comes every day or every carousel in UK recently. They are asking this question.
Okay.
I think every day about the tramadol in epileptic patients. And I tried to ask many neurologists and neurosurgeons about tramadol. Some neurologists told me it lowers threshold of epilepsy and it increases the fits, and is completely contraindicated in non-epileptic patient. It should be avoided. And some doctors told me that it sometimes is a complication, as you said lately about this patient. But I want sometimes are taking that epileptic patient control for 10 years of over medications, and he received tramadol for pain control. Then we get epileptic fit, as the doctor mentioned lately. So my question also, is it still an error, or maybe a communication error between the GP and the neurologist?
So the question is, if this patient is controlled and suddenly he has epilepsy following initiation of tramadol,
Yes.
is that the only reason why this patient can develop epilepsy at the moment?
No, he had UTI also. This patient had UTI.
And the surgery.
And surgery, okay.
The stress,
sometimes surgery, sometimes
whatever
yes.
can precipitate the epilepsy.
Yes.
So we are not sure about that. But is epilepsy a common side effect of tramadol?
In epileptic patients, it can induce seizures, but not.
The question here. Thank you. This is the point. This is what I'm going to check for. If this medication is contraindicated in epilepsy, it's an error. But if not contraindicated, it's not an error.
Yes, and I guess it's contraindicated after counseling many consultants of neurosurgery. It's contraindicated in epileptic patients, tramadol, by name. Doctor, I have
any feedback on this case from examiner?
No, I don't have feedback.
This is the problem. This is the problem. Examiners will disagree. But anyway, yes. What else?
Just this was another question, please, doctor, about breaking the confidentiality of the patient. Some patient came to the I took the patient, the father of the patient who is receiving alcohol and intravenous drugs, and she is alcoholic and drug addict, and she went to coma due to hepatic encephalopathy. And I'm talking about with her father about her condition. Shall I break the confidentiality and tell her that he is alcoholic and IV addict, and this caused her liver affection, or just tell her that she has liver affection and I can't break the confidentiality for the cause of affection?
This is a good question. So, whenever you're starting a case of communication, you always start by asking the patient if she has a permission from her daughter to discuss the condition or not. So, if she has a permission to discuss everything regarding the case, you can tell her whatever. If it's mentioned in the scenario that the daughter doesn't want coma, okay,
yes,
is the father or the mother is the next of kin or the lasting power of attorney?
Yes.
If she is the next of kin, she has the right to know. So you will tell her about it. Yes, she has the right to know everything about the diagnosis, the management plan, and to accept it or refuse it.
Even if the patient has HIV, I can tell him that she has HIV and she's in a coma because of HIV.
Are you sure that the coma is because of the HIV?
Not sure, but she has HIV and she is alcoholic and she is drug addict. Can I explore all these
Send me.
problems?
Do you have the scenario? Do you have the scenario? Hold on.
It was
Step by step.
in post test videos, and he told him everything. He told his father everything. She's addict, alcoholic, HIV, everything.
Hold on. Whenever it comes to the confidentiality, first of all, we always check the patient. Then the second line should be the advance directive. The third line is the lasting power of attorney. Then the final point is going to be the next of kin. This is the order. The patient is in coma. Did not specify anything to be said or not to be said. There is no lasting power of attorney. Now you are dealing with the next of kin.
Yes.
The next of kin wants to know everything about the condition. Does he have the legal right to do that? Yes, he has the right. So you will tell him everything regarding the diagnosis, the management plan, and he has the right whether to accept or refuse. This is the autonomy. If he accepts a medical decision in the best interest of the patient, fine. If he refuses a medical decision in the best interest of the patient, you will go to the legal team.
Yes. Okay.
This is long story short.
Yes. Thank you very much.
Thank you, doctor. Okay. We have one more case from yesterday, and I'm not sure who had that case. So we will wrap it up for today. And we will continue tomorrow, inshallah. Tomorrow we'll target station 2, 4, or 5. Will depend on the poll and Telegram. So thank you, everyone. And keep feeding me with cases regarding the recent diet. And tomorrow, inshallah, is a new day. Thank you, everyone. Have a good night. And Assalamu alaikum.